Welcome to EconTalk, brought to you by the Library of Economics and Liberty. I'm your host, Russ Roberts of George Mason University, podcasting today from Stanford University's Hoover Institution. My guest today is John Cogan. John is the Leonard and Shirley Eli Senior Fellow here at the Hoover Institution and a professor in the Public Policy program at Stanford University. He's also the author of Healthy, Wealthy, and Wise, 5 Steps to a Better Healthcare System, a book he's written with Glenn Hubbard and Daniel Kessler. John, a lot of people say you can't trust the market to handle healthcare. After all, look how badly it works. Costs are out of control, millions are uninsured. What's your response to that claim?
Well, healthcare is, in fact, very similar to every other commodity, although people don't perceive it to be so. People somehow think of healthcare as being special. But ask yourself, is healthcare any less important than food and shelter? And the answer is no. What's different about healthcare is the way we consume it and the way we purchase it. And what I mean there is that we don't see ourselves as spending our own money for most of our healthcare.
Unlike, say, food or
That's right.
summer housing.
That's right. Right. Most of our healthcare is purchased through third-party payments. And what I mean by that is most of our healthcare is paid for by our employer, our insurance company, the government, not by ourselves directly by making out-of-pocket payments. And it's very different than, of course, it is for food and shelter.
So in the case of food, if I want the sirloin steak rather than the hamburger, I have to pay more.
Right.
But in the case of health care, it's often not my dollars are going to make that choice.
Of course, ultimately they are our dollars, right? But for that particular service, no. You might pay 20 cents on the dollar, and the insurance company or your employer or the government, in the case of Medicare, would pick up the remaining part.
And that's changed over time.
Yes, it has. In fact, it's gotten, I would say, I'll use the term worse. Individuals are paying for less and less of their health care directly through out-of-pocket payments and relying more and more on insurance. Now, it's okay to rely on insurance for very expensive, catastrophic illnesses.
Unexpected events.
Right. But for routine care, what happens is as people perceive themselves as using somebody else's money to finance their routine out-of-pocket expenses, they end up purchasing more and more out-of-pocket, more and more health care that has relatively low value.
Low value in what sense?
Low value in the sense that the costs are very high and the contribution to your overall health care is very, very low, or that its ability to produce a positive health care outcome is very, very low.
So normally you'd say, well, that's bizarre. Why would somebody pay a lot of money to get very little in return? But you're suggesting that there's a high cost, but you don't pay a lot of money. For you, the cost is relatively low, so you're buying something that's relatively unproductive, but still worth it because of this implicit subsidy from the third party.
That's exactly right. And why does it produce what we might think of as inefficient health care? Well, Milton Friedman once said, nobody spends somebody else's money as wisely as they spend their own.
So true.
And well, that's what we're seeing in healthcare.
One of the deepest insights, I think, of human behavior. And that alone, that insight by itself is a spectacular guide to public policy design.
Isn't it?
A lot of things we do wrong come from ignoring that principle, I'd say.
That's exactly right. And that's why our healthcare costs have grown so much, and why people perceive that although the healthcare system is phenomenal from a scientific standpoint, at the delivery level, it's not working right, and people are frustrated and upset.
When you talk about it being fantastic at the technological level, a lot of the higher costs that result from this incentive problem are beneficial. We do get good quality care in many dimensions, right?
Absolutely right. Absolutely right. There's a lot of people that say, well, we should try to separate the good technological advances from the bad, and what I say is let's let the market do that with the proper incentives. It's very interesting about technology. healthcare technological change is very, very different than technological change in just about every other area. In every other area, we've seen technology that raises quality and technological advances that reduce costs. Right. In healthcare, we see technology that raises quality, but we rarely see technology that reduces costs. And I think the third-party payment system that we have that dominates our healthcare system in the United States is in part responsible for that. It's very interesting. If you look at parts of healthcare that are not covered by insurance, such as cosmetic surgery or LASIK surgery for your eyes, what you've seen there is a tremendous reduction in the cost of those services and those procedures as a result of technological advance. And we don't see that same kind of cost-reducing technological progress in areas of healthcare that are dominated by insurance.
Could be just a coincidence, but it's probable that it's due to the incentives there.
Hercule Poirot would say there are no such things as coincidences.
Well, I'm going to stick with this issue because I think it's really interesting when I hadn't thought about it. There are some technological advances that have lowered costs, not in the normal sense in which we think of technological advances, say making a computer faster or having more storage. In the case of healthcare, pharmaceuticals have sort of done an end run around this in substituting for surgical procedures that might be necessary, preventing things that might require more expensive things. So there's an example where there's a technological advance that did lower costs, but that's not what you're talking about. You're really thinking about, say, devices that look inside your body.
Right.
So you start with a rubber hammer. You bang it on somebody's knee. You thump somebody's chest with your fingers. The doctor does that, and you learn something. We advance, we get X-rays. We advance, we get MRI. We get CAT scan. We get better and better. So we do get these improvements. But you're saying within a technology such as MRIs, we don't see the cost reductions we normally see in other areas of industry. Is that right?
You put it very well. Better than I have.
So, well, doubt that, but I want to think about why that's true. Now, why would that be true? Why? One answer could be, well, it's just something different about healthcare. It doesn't lend itself to these kind of improvements that work in, say, cars or computers, cameras, toasters, clothing manufacturing, food production, all these areas where it gets such improvement. What is different about healthcare? Is it a technological aspect of healthcare, or you're suggesting is something different?
I think it is something different. I think it is the fact that individuals, since they're not paying or don't perceive themselves as paying for the services they get, do not demand cost-reducing technological advances.
And there's no return, therefore, necessarily for the manufacturers to make those improvements. There's also you might call it a bells and whistles phenomenon, where small improvements in quality that are very costly, that a market would normally reject because they're not worthwhile, in this area don't get rejected for the reason you're talking about. Right. And that really brings us to an interesting point about this cost increases. And I just want to emphasize again, I know both of us agree on this. We're not saying that just because we spend more in healthcare, that's bad. As we get wealthier as society, certainly, like many other things, we're going to spend more money on certain areas, less money on others. And healthcare is an area where I think we'd predict in economics that is what's called a luxury good, or where people are going to want to spend more on it as they get wealthier. A normal good is the technical term in that case. But that's not our complaint here. Our complaint is that it's the bang for the buck. And this interesting example of technology really interacts, I think, with another point you raise in your book, Healthy, Wealthy, and Wise, about defensive medicine. So if the legal environment punishes mistakes in a very aggressive way, which has a plus, which is we don't want people to take we want people to take care. We don't want negligence. But if the legal environment overly punishes people and encourages people to practice defensive medicine, technology will always be attractive. In fact, will be almost improvements in technology will suddenly become advantageous to a practitioner for legal reasons, but not for medical reasons alone. Talk about that.
That's very true.
Is that a long enough question for you? Sorry about that.
Well, let me try to give you a short answer to the long
apologize.
question. It is very true. And it's also the case that if a technology exists and a physician is on the margin as to whether this might be an appropriate procedure to use, a test or whatever on a patient, the existence of, on the one hand, a badly out of sync medical liability system, and two, the fact that the patient is not paying for much, if anything, for the cost of that test, leads the physician then, of course, to order up the test. And so both factors combine to produce a fairly significant incentive for physicians to order up tests and procedures that he might not do so if these markets were functioning as they should.
And, we don't even think it's strange anymore, but if you're in a medical care environment and somebody runs a test on you, you just sit there. Most people just sit there and take it. They don't say, well, I don't want that.
That's right.
Sometimes
they certainly don't ask, how much does it cost?
Which is unlike any other, as we talked earlier, unlike, say, food. You don't go to a restaurant and all of a sudden you find a bunch of desserts on your sitting in front of you, and they say, well, I didn't order that. Well, we thought it'd be good for you or bad for you, whatever. Let's get to the root of this. So you mentioned earlier that third-party payments are substantial and increasing in America over the last few decades. I think in your book you use the figure of 5/6. That is, only 1/6, about 16 cents on the dollar, is paid for by the patient. And of course it varies a lot by patient, so some patients are getting everything paid for. A lot of procedures then are perceived by the patient rationally to be free, imposing the costs on others. How do we get there? How do we get to that world? We don't see that functioning in the markets for food or computers or other things. Why do we have this world where there's so much third-party payment?
Well, there's another interesting fact before getting to the answer to the question. Another interesting fact is that 9 out of every 10 privately purchased health insurance policies in the United States are purchased through an employer. And the two statistics, the 9 out of 10 health insurance policies that are purchased through an employer, and the fact that only 1 in every $6 of medical care spending are paid for by the individual, go hand in hand.
That's a weird thing. I don't get my car insurance from my employer,
you certainly don't.
I don't get my I might get life insurance, a little life insurance for my employer, but most of us buy those things privately on a competitive market, regulated somewhat by state, sometimes federal regulation. But what's the cause of this?
Well, most economists think that the cause of it lies in a government policy blunder that was made nearly 60 years ago. And the policy blunder was to make all medical care purchases that are made through an employer to be excluded from taxation. So if you purchase medical care through your employer or through an employer-sponsored insurance plan, it escapes all taxation. If you purchase medical care directly on your own or you buy an insurance plan directly on your own, you have to pay for that purchase with after-tax dollars. And so the tax code created an enormous financial incentive for individuals to buy insurance through their employers, to buy as much of their health care plan through their health care services through their employer. And so it has contributed not only to the 9 out of every 10 health insurance plans being bought through employers, but it has also led to individuals to buy plans that have low copayments or low deductibles. That is, that cover a broad segment of services and have the insurance plan pay for 90%, 95% of the cost of the services that are covered.
And you're suggesting without that tax treatment of the employer-provided health care, I would not choose that on my own. I would choose to have a higher deductible and certainly a bigger out-of-pocket expenditure per unit.
That's exactly right. That is exactly right. The estimates that the economists have come up with about the importance of the tax policy for driving healthcare costs are there's quite a wide range to them. But I think the modal estimate, the one that most economists would agree to, is that the tax code alone accounts for 20% of the higher costs of insurance, or 20% of insurance costs.
So if we got rid of that provision, we could lower insurance costs by 20%, expand, make insurance more attractive to a wide group of people.
Right. Now, what's really interesting about the work that's been done in this field, and some of which we report in the book, is that much of the increased healthcare consumption that people buy because they have low deductible insurance doesn't contribute to an improved healthcare status for the individual.
So you get more healthcare, but you don't get healthier.
Exactly. And so how do we know that?
Yeah, that's a good question.
Well, back in the 1970s, the United States conducted or financed a social experiment in health insurance, and it was run by the Rand Corporation. The Rand Corporation enrolled thousands of families into one of several experimental health care plans. Some of the health care plans had low deductibles and low co-payments. One of them had free care. So long as you paid the premium, you would get free care. Other plans had high deductibles and high co-payments. And they watched these families over the course of several years and observed how they altered their consumption of health care services. And what the Rand researchers found was absolutely fascinating. People that were enrolled in the high deductible, high co-payment plans ended up consuming significantly less health care services, or significantly fewer health care services. However, by and large, for most of the population, there was no difference in health outcomes among those that were enrolled in the higher deductible and higher co-payment plans and had spent less than the people that were enrolled in the free care plan. And so it has led to the conclusion that much of what we purchase because we have low deductible, low co-payment plans is not really health care that's leading to better health status for us. And so when it comes to the implications for public policy, that means that if you did change the tax treatment of health insurance, you shouldn't expect it to have much of an effect on the level of health of people in the United States, but it would contribute to a very sizable reduction in the cost of health care.
Giving us more resources to spend on other things that we value, making life better.
Including higher valued health care.
Now, I want to digress for a moment because I think you touched on something very important that you often hear people misunderstand. You said that in this Rand experiment, people who faced lower prices consumed more health care. And the economic jargon for that would be a downward sloping demand curve. As the price falls, people consume more or something. I think people a lot of time make the mistake of implicitly assuming that the demand for health care is vertical. Health care is something you need. And what they have in mind, I think, is that you get in a car accident and you need surgery to save your life, and you'd pay anything for that. And of course, in that situation, price would not be an important determinant of whether you got health care or not. But in most or many situations, lower prices do encourage people to, quote, use more, get that extra test, get a procedure that might improve health a little bit but might not, and that what we might call discretionary healthcare is a much larger percentage than what we have in mind. But there's a lot of demagoguery and ideology here where people like to scare people into thinking healthcare is, you need it. You got to have it, and so we can't let the market determine it. But you're suggesting this Rand study clearly showed it's a much more complex issue. So the current situation, the current tax situation, encourages people to consume more health care than they might in a less in a different world where they were responding to prices more directly. What other factors are involved? One factor you talk about in the book is state regulations. Talk a little bit about how state regulation of healthcare has driven up costs with little or no health benefits.
Well, increasingly over the last 30 years, state legislatures have imposed requirements on insurance companies to cover specific services and procedures and types of providers. And so many states have laws that require individuals who are firms that offer insurance to include chiropractic care or acupuncture and so on. Those types of mandates, and if you look across all states of the union right now, there are 1,500 individual mandates or requirements imposed on insurance companies to provide certain services.
But that's good, John. Isn't that a plus? I mean, that way more people have more. They're sure they've got this thing covered.
They are sure they've got this thing covered, and they are sure they are only paying, they perceive, maybe 20 cents on the dollar for it. And that's one reason why we have these mandates. But the fact is that the mandates tend to drive up the cost of insurance for everyone.
So if I have no interest in acupuncture and decide it's not for me, I still have to pay for the option of using it down the road.
That's exactly right. That's exactly right. Or take one that's a little bit more sensitive. Maternity care. Mm-hmm. In California, we have a requirement that insurance companies have to offer a plan.
If they offer a
plan, their plan, right? Yeah. They have to have maternity benefits. That raises the cost of insurance for everyone. But for particular groups, it really raises the cost of insurance. For women aged 30 to 34, the estimates that we have indicate that mandate raises the cost of insurance for the typical woman in that age bracket by 50%.
Wow.
It's an extraordinary number. And then you have to wonder, well, yes, many people would benefit from this mandate, but you have to recognize that many people are paying the cost of this mandate. And there's a fundamental question that has to be asked, and is, do you want a politician determining what benefits you're going to have and what you're not going to have in your insurance plans, or are you willing to let the market do that? We seem to, in the United States, have gone down this road towards having the politicians do it, and the politicians are not only responding to the general public on some of these matters, they're also responding to special interest groups, sure. Special types of providers, yeah. And so forth. But that's not the only area where we've seen an increase in regulation. We've seen a lot of states adopt rules that limit the ability of insurance companies to offer lower prices for their products.
How does that work?
Well, what they're concerned about, what the regulator is concerned about, is that some small businesses might have some employees that are very high cost, and that would generate a high premium. And so they want to protect those small employers from that high premium. And so they will slap a price control. Most states have these in their small group market. They will slap a price control, the maximum price that any insurer can charge a small employer. At the same time, though, they then slap a minimum price on all small employers. That is, an insurance company cannot offer a plan below a certain price as a way of paying for the protection that they're trying to give to the company that might have high costs. What are the consequences of this? Many small businesses, simply faced with this high price at the lower end, say it's not worth it to have insurance, and so they don't offer their employees insurance. The result is that the good risks are absent from the pool of insured, right. And that further drives up the cost of health care.
Well, let's focus on that for a minute. Let's start with the first point you made about the ceiling, the price cap. So you're saying if I'm a small business, I have a small group of employees, I don't have a big risk pool to spread risk, a big pool to spread the risk over, and I might have a couple employees with very high risk conditions or for whatever reasons use the system a lot. So I'm going to have high insurance company, to make it worthwhile for them, is going to want to charge me a high price for my employees' health care. So to protect the employees in that business, the state puts a cap on. And that's going to discourage, that by itself is going to discourage the provision, I assume, of health care to small businesses by the insurance companies.
You got it.
I can't profit.
That's
I can't cover my costs. Why is it, we're opening a Pandora's box here, but why is it that a small business would be offering insurance that's spread over its employees alone? Why don't we see wider markets for health care the way we see in, say, life insurance? Let's take life insurance. Let's say I work at a firm where everybody's really old. Well, if the company had to insure me and everybody's old, well, life insurance is going to be very expensive, right? But that's not the way life insurance. Now, they'd, of course, price it according to age if they could, but it's sort of what we'd be doing in the healthcare market by using such a small pool. Why would we do that? Why aren't there national health insurers that pool my risk with thousands of other people instead of one small company having its own pool? It makes no sense. So what's going on there?
Well, that's a very, very difficult question as to why we have this peculiar arrangement. But again, here's a case where government policy has at least contributed in some part to the problem. We have a system of regulation of insurance in the United States that is state by state. Many decades ago, the United States Congress decided, the Interstate Commerce Clause of the Constitution notwithstanding, that
it's never stopped them before.
That's right.
In recent
That's
decades.
That's right. That each state should have its own insurance laws, or could have its own insurance laws, and there'd be no interstate commerce in insurance. And so if you live in South Dakota, you cannot buy an insurance policy that's approved in Indiana but not approved in South Dakota. And so one of the policies we have recommended in our book is that individuals should be allowed to purchase insurance from any company that has an approved product in any state. That is, we should allow for more of a national market for health insurance. And that would tend to increase, in certain states particularly, tend to increase the size of the pool that's available to pool risk for insurance. So we think that makes an awful lot of sense. Give individuals more choices, give individuals more opportunities to get into a bigger pool. So I think that's a very, very important point. And when it comes to regulation, what we're saying is you don't have to have a completely deregulated market. What you have to do is recognize that when you over-regulate our healthcare markets, insurance markets, the way we have, driving up costs in California by as much as 25 to 30%, you end up pricing many individuals and small employers out of the market. And that then creates a vicious cycle in insurance. The good risks are not part of the pool.
Yeah.
It also creates another problem that is in the popular press today, which is the problem of the uninsured. We now have 40 million people that at some point in time during the year go without insurance. Part of the reason we have that problem is we have over-regulated the markets, failed to recognize that the costs of regulation price people out of the market. And so what we're recommending is to go back in the other direction, look at the costs that regulation is imposing, and see if it makes sense to deregulate the market a little bit to get the cost down and increase the pool of insured people and reduce the number of people who lack health insurance.
That problem, the uninsured, I think the media treats it a little bit in a confusing way. Just because you don't have health insurance doesn't mean you don't have access to health care. We really don't care whether people have insurance. What we care about is whether they have access to health care and health services. Unfortunately, some of those folks don't have health insurance. The way they do get their health care is a very ineffective way, through emergency rooms and other things that are high cost, again, costs imposed on other people. It's not well known, but I think what is well known is that if you open an emergency room, you have to take everybody who comes in. What's not well known is how many people show up who have no intention of paying, and those funds never get collected. I know that when I was here at Stanford 20 years ago, Stanford's emergency room in the hospital here, I think, collected about 50 cents on the dollar of every dollar that was charged. I don't know if that's typical. Do you have any understanding of it?
Yeah, there's an excellent paper in Health Affairs a couple of years ago that looked at spending on the uninsured. And what they found was very interesting. We spend, or the society spends, about $100 billion a year on health care for the uninsured.
$100 billion.
$100 billion, all right? But then you start breaking it down. Half of that is paid for by the individuals themselves.
Just out of pocket in a clinic. Or...
Right. And so now we're down to about $50 billion. The federal and state and local governments provide an awful lot of charity care through special federal payments to inner city hospitals. You have county hospitals, community health clinics. The government governments combined spend about $40 billion on charity care for the uninsured. Mm-hmm. And so what you're left with is no more than $10 billion, some estimates are even less, $5 billion, that is imposed by the uninsured on the private healthcare system. Uh-huh. And so, as you said, when people use emergency rooms, they're using a less efficient form of care. They're getting the care.
Because it's not an emergency. I just want to make that clear.
Yeah,
people should,
right. Yes.
A mom with a kid has a sore throat, think it might be strep, can show up at an emergency room and try to get a test.
That's right. And the costs of that are imposed on the private healthcare system, certainly. But you have to keep in mind that the magnitude of these costs are not that high when considered against the total amount of private sector health insurance expenses that are incurred. The uninsured might account for less than 1%, perhaps as much as 4% of the costs of insurance for the typical family today. So this argument that we can reduce the cost of health care by covering more individuals through another government program are just simply wrong.
Now, we talked about some of the problems with the current system. Let's talk about some solutions. One solution, of course, is we need more government. The system's broken, greed's run amok in the medical profession, the pharmaceutical companies, etc. So what we have to do is have more regulation. We've got experiments about countries that use more regulation, such as Canada, United Kingdom. But you would take us in an opposite direction.
That's right.
Tell us about what you'd recommend.
Well, it seemed to us that the first place to look is at the unintended consequences of government policy. And when you find that the unintended consequence of a government policy is to raise the costs far greater than the value that the policy provides, let's undo that policy. And let's see if when we allow markets to work properly, we will get the costs down and we'll get a more efficient system. So that was sort of our general approach. And we had several specific areas where we had recommended an alteration of an existing government policy. The most important of which I felt, and I think my colleagues feel the same way, is in tax policy. As I said, the tax system that we have today encourages people to purchase insurance for all of their health care expenditures, or as much as they can, and purchase it through their employer. So we have an unlevel playing field, tax-wise, between insurance and out-of-pocket spending, between buying insurance on your own and buying it through your employer. let's level the playing field, we say. Now, there are two ways to do that.
Yeah.
Right? One is you can eliminate the tax exclusion, and the other is that you can allow out-of-pocket spending and individual purchases of health insurance to have the same tax treatment as employer-sponsored insurance. We, being practical men, realize that the chances of the United States Congress eliminating the tax exclusion are slim to none. Okay. It would amount to your congressman saying, "Hi, my name's Joe Smith. I'm from the government, and I'm going to help you with your health care costs by taxing your health insurance benefits your employers provide."
Now, if people understood economics a little bit better, they might see the connection between that distortion and their higher costs, but unfortunately, that knowledge might not be as widely available as we'd like. So
that's right.
You come up with a more practical strategy.
Well, I should say this. Back in the early 1980s, President Reagan proposed to put a limit on the amount of employer-sponsored insurance that would be excluded from taxation. I think it was $5,000 or $3,000 at the time. Right? I was part of an administration group that was sent up to Capitol Hill to explain the policy. And I got up to the office of a congressman named Jack Brooks, who was a veteran of many, many years of congressional service, Democrat from Texas. And I walked in the door to explain the policy, and he said to me, "Mr. Cogan, you don't have to explain your policy. I understand it." He says, "Let me tell you something. I've been around this town for many, many years, and you have managed to do something that I have rarely seen in all my years." I said, "Well, what's that, Congressman?" He says, "You have managed to unite the AFL and the Chamber of Commerce." And he promptly threw me out of the office.
Yeah.
So that policy had a half-life of about a week.
Interesting educational experience.
Right. So,
too bad.
So
courageous, though, and wise, but
I was a young second lieutenant, if you will, not knowing any better. But in any event, that policy doesn't seem to have much chance of being enacted. So we have proposed a really practical idea of allowing individuals to deduct their out-of-pocket payments as a way of putting payments that you make directly for your health care services on a par with payments for insurance.
And it's a slightly older and much wiser soldier in those policy wars. What do you think's the political likelihood of that happening?
I think it's
a great idea.
Mm-hmm. I think it's
clever.
Actually quite good. I think it's actually quite good. And the reason I say that, it is the direction that federal tax policy with respect to health care has been moving for about 2 to 3 decades now. Mm-hmm. We now have special arrangements with employers that permit employers to allow individuals to deduct some of their out-of-pocket expenses. Stanford has such a plan. Many big employers have that kind of a plan. There's a new device, a federal device, called health savings accounts that allow means for individuals to deduct their out-of-pocket payments. And so policy has been moving in that direction. We say take it a very, very big step. Once you level the playing field between insurance and out-of-pocket spending, then what you'll see over time is gradually individuals will begin shifting towards plans that have a lower premium and a higher copayment. And as the effects of those higher copayments become evident, we'll see the growth in the cost of health care gradually and slowly subsiding. We'll see a change in the way technology progresses, and we'll see a greater tendency towards cost-reducing technology. And so we think that the fundamental problem in healthcare is the third-party payment system for routine care. The source of that problem lies in the tax code, and it's fundamental to healthcare policy, therefore, to eliminate that fundamental tax code problem. And we think it'll have a powerful, long-term effect on the way we consume healthcare in the United States today, and do so in a way that is that makes people better off. They'll be able to keep more of their income. So we think it makes good policy sense, and it's also good politics.
Yeah, it's good politics. I want to digress for a minute on this political issue and draw on your knowledge as a political warrior. Very interesting point you make of that trend over the last few decades of moving toward deductibility. And the reason it grabbed my interest is that politicians like to take credit for stuff, inevitably. They don't like to let solutions emerge that are private and voluntary. They like top-down, hierarchical, imposed solutions so they can wave them about. So they kind of do that, but they do allow market forces in the political world, maybe, what you're suggesting, push us toward a market-oriented, incremental market-oriented reforms. You can't get a global market-oriented reform. You can't just get Congress say, yeah, we've made a big mistake. We shouldn't have been doing all this regulation stuff. Let's clear the playing field and let them go at it. Instead, they say, well, we'll tweak this and tweak that. And the reason it fascinated me is it really reminds me of what we've done in tax policy overall, where economists want to see a consumption tax because the current system punishes savings and makes consumption overly attractive. And it seems extremely hard to get a global tax reform through, but we do tweak the system in that direction systematically almost, not literally systematically. No one's designing it. But you're suggesting, just something I've never thought about, that's been going on in healthcare also. Really makes me cheerful. I really like that.
Yes.
Want to say anything else about that? It's really interesting.
Well, I think it is very, very interesting, and it's the way democracies work. Rarely do you get a big bang change in policy, global solution. By and large, what you get is incremental solutions. Politicians are very risk-averse people,
right,
for the most part, and so they don't like big bang solutions. What we like about the policy that we have proposed for tax deductibility for healthcare is that it's based upon a large body of scientific evidence on how people behave when faced with different incentives. Incentives matter, and they matter big time in healthcare. And what we'd be doing here is correcting a fundamental incentive that people have towards higher insurance for routine care and hence overconsumption of medical care. A second policy area where we've proposed reform, as I mentioned earlier, and I think this is a very big reform, is we would allow for a federal market in health insurance. Now, it turns out there already is a federal market. It's a very interesting historical development. But in 1974, the United States Congress decided that the federal government should regulate pensions. And so they passed a law establishing federal control over pension policy. States are not allowed to interfere in that realm. One consequence of that policy, that law, was that if an employer self-funded or self-insured his health plan for his employees, that would no longer be regulated by the states. It would be regulated by the federal government.
And the federal government piece, this is called
ERISA, the
ERISA, right?
The
stands for
Employee
something.
Retirement Income Security Act of 1974.
So this could actually be one of those rare examples of a positive unintended consequence, right? That was a pension regulatory scheme, but you're saying that had some implications for healthcare benefits.
That's exactly right. So now every large employer in the United States that has the ability to self-insure, Stanford University does, George Mason I'm sure does, virtually every university does, now has a choice. They can opt to be regulated in the federal market, or they can opt to be regulated in the set of state markets that their employees are in. And the vast majority of large employers have opted to self-insure and fall under the federal regulatory market. No law, however, is without its bad unintended consequences.
Yeah.
And so it's interesting that's what's happened in the state capitals. So this law was passed in the mid-1970s. And if you look at the growth in these health insurance mandates that we see, 1,500 of them in all of these state laws across the union, we see the growth in these mandates take off beginning in the mid to late 1970s, and they continue growing for the next 25 years. Okay?
What's the connection?
What's the connection? Well, prior to the enactment of ERISA, when a specific group came in to lobby the legislature to have their group mandated in an insurance plan, say chiropractors or acupuncturists, the large employers and small employers would combine and present a political opposition to that, because they would be paying the costs of that mandate.
And their employees,
right?
Indirectly.
And their employees indirectly. That's right. Yeah. That's right.
Lower
That's
wages,
right.
presumably.
You got it. That's right. Better put. Well, after ERISA, the large employers left the market, the political market. And now, since then, it's been up to the small employers to combat these narrow interest groups that are pressing for these mandates. And they have just been overwhelmed.
They don't have the political economies of scale that you need to unite.
Right. And at the federal level, there's been the same kind of pressure to have requirements in the federal market.
Sure.
Yet we have very, very few mandates in the federal market. The reason? We have had large employers being an important and powerful political bloc to prevent the enactment of these mandates. And so my view...
That's a very interesting story.
Yeah. So my view of public policy is, in many instances, you want to set up a political market where there's a level playing field between all of the competitors in that political market. And you don't want to set up an unbalanced system. And what we did with ERISA is, in some sense, create an unbalanced system. But we can't, in some sense, be trying to tilt the market one way or the other. We should have a balanced market, and I think the founding fathers would have agreed to that, and let them fight it out in that political market. And so what I say is maybe we should have a greater dose of governmental competition. By allowing small employers and individuals to have an alternative to the state market. Let them, just as the large employers have the opportunity to purchase in a federal market. And let's have a little bit of competition between state governments and federal governments as to which market would prevail in providing the lowest cost insurance for the most individuals.
Now, talk for a minute about the political challenges of that reform. Who's going to line up to stop that? And so basically you're saying, let's level that playing field. Let's get rid of this distortion that encourages large employers out of the state market and makes state regulation special interest oriented. If we did that, that seems like a good thing. Who's going to vote against that?
Well, certainly insurance companies, and small insurance companies in particular, are going to be against that. Right now, the way that regulation works in insurance at the state level is very similar to the way regulation tends to work at every level of government. There's a trade that gets made. The insurer limits the competition that's faced by the insurance regulator, limits the competition that insurers face, and in return, the insurance company gives up some ability to make profits.
Right. And
so you get rate regulation in return for protection from competition. Well, competition is not very good for insurance companies as it isn't for any producer of a good, but it's darn good for the consumer.
Right.
All right. And so we feel that the insurers, especially the small insurers that operate in particular states, would be vehemently opposed to this type of policy. Because now they'd be forced to compete with other insurers in other states.
I see that.
Right? We also have heard from insurance commissioners in the states. Of course, this would remove some of their power to regulate the insurance sector. They'd be forced now to compete, if you will, with another regulator that's offering lower regulations.
So the politics on this is a little bit weird. The federal government is going to expand, and if this were to pass, the federal government would have more autonomy, more authority.
Right.
But a senator from a particular state is going to hear from that state's insurance commissioners, that state's insurance companies, who are going to be worried about the impact on them, and that's going to be where the lobbying probably takes place.
There's another important point that I want to make here, and if many of your listeners probably have some familiarity with the law, maybe some of them are even law students. But one has to ask: is the current way that we regulate insurance, state by state, is that a violation of the Interstate Commerce Clause of the Constitution? My belief is that it is. I don't see insurance as being different than any other commodity, and I do see that what motivates an awful lot of insurance regulation at the state level is protection of in-state providers of the product against out-of-state competition. And that's what the Interstate Commerce Clause was designed to guard against, the ability of states to prevent commerce free-flowing from one state to the next because of barriers to trade imposed by the states. And so we think it would be at least an interesting exercise for some good law school students to maybe bring back this question of whether now, in light of modern technology, the internet, whether it makes sense to have a much more of an interstate market and get rid of this anachronistic McCarran and Ferguson law, which is the law passed in the 1940s that gave states the ability to regulate insurance.
More hope for the future. Well, we're out of time. I want to thank John Cogan, the author of Healthy, Wealthy, and Wise, 5 Steps to a Better Healthcare System, for a fascinating conversation on healthcare. There are other recommendations in the book. You've talked about the 2 biggest ones, but there's, in addition to other recommendations for improving the system, there are a lot of interesting facts, and it's a short book, which I want to mention.
It's a readable book.
I'm a fan of short books. It is 88 pages, and it has a lot of interesting ideas, a very provocative treatment of this incredibly important issue. For more EconTalk, please go to econtalk.org, econtalk.org, where you will find other podcasts, as well as links about this issue of healthcare and the reforms that we've been discussing. Thank you, John.
You're welcome, Russ. Thank you.